you for joining us today. We're very excited. Carol and I will do some introductions here in a second to talk to you about the title of this presentation. There's going to be later topics where we get more into the nitty-gritty of induction and maintenance and tapering off. And when Carol and I got together to talk about this today, we really wanted to give everybody kind of some fundamentals, some basics, structure. Because when you get in, get your hands dirty, it's good to have your boots on, right? So that's kind of what we were thinking. So I'm Kresh. I'm the pharmacist at Hopes. And
I'm Carol Hain. I'm a physician's assistant at Hopes in the MAT program.
And I'm Seda Altenson, psychiatrist and a MAT provider.
Mark Broadhead, addiction psychiatrist, VA Medical Center. I run the Suboxone program over there.
I'm Pete Ledlow, registered nurse. I'm the nurse case manager for the MAT program at Northern Nevada Hopes.
And I'm Danica Pierce. I'm a licensed clinical social worker at Hopes in the MAT program.
all right, let's get started. See if I can do this here. Here we go. So, I apologize for the crudity of this model. It wasn't drawn to scale. Anybody can name the movie? Probably not. So the title here is Opiate Receptor. And in this very poorly chosen picture, chosen by me, the pharmacist presenting this here today, you see here on the left, it says, a full agonist binds to the receptor and activates it, changing its shape, inducing a full receptor response. And then on the right, a partial agonist, a partial response. You know, this is very simple, but it means everything if you're an addict. Because we know that addiction is a chronic relapsing disease. A pharmacist that I was working with said to me, and I thought it was kind of cute, but it kind of makes sense. He's like, you know, if I'm an opiate and I'm trying to produce a response, it's like a full bro hug, a bromance hug and a fist pump. It's everything. But with buprenorphine, it's different. It's just like a partial hug or a partial fist pump. This is huge because if you have an addiction, if you have a problem, that partial response gives you the ability to feel, if you're an addict, normalized, functional. Your cravings are less. It's almost like a crutch that's there in the background. And that's what makes buprenorphine so cool and so different. And there's nothing else like it that we know. So that's why we're excited to talk about it with you. One of the things, and I'm gonna kind of go off on some tangents and talk about other points, is that, you know, buprenorphine is medication and it's dope, okay? It produces euphoria. It can cause dependency. The sales of it surpassed Viagra and Adderall in 2012, $1.5 billion. It has successes and it has failures. It is a street drug. It is a prison drug. But when it's used appropriately and for people that can be successful, it is life-changing. And that's what's so unique about it. And that's why we use it. And we're going to talk a little bit about the history of it, where it came from, because that's really cool too. I really love this slide because somebody in our group here had so deftly said that for every twisted thought, there is a twisted molecule. This is what makes treating addiction so freaking complicated and why it drives us all crazy, because it's a biobehavioral problem. So here on the left, you have all the opiate receptors. We used to think there was just one, but now we've subtyped them into different groups. And then kind of in the middle there, you have a picture of an opiate receptor. It could be something my kids drew. I mean, what do we know? And then on the right, we have all the effects that we know that they cause. If you're an addict and you have an issue, I said, what you're seeing here on the right is all these other responses that you have to deal with an individual. And of course, there's the worst one on the sub-2 receptor, respiratory depression, the costs that has affected in terms of on our system, on lives, on individuals. It is crazy. A lot of the things that Carol will be talking about later when we talk about addiction and euphoria and so forth is all this stuff plays into the same pathway that plays into dopamine, where we feel reward and we feel like things are being able to be done again, over and over, the pleasure, all this stuff. This goes in with that. And so not only are you dealing with somebody like Danica says with their trauma and so forth, but you're also dealing with this. Buprenorphine is very interesting because the effects are milder. It plateaus, so overdoses are less likely and less deadly. Interestingly enough, on a side note, because of what it is, one of the ways that, unfortunately, in the prison system, what happens is that people are so desperate for it because it helps them so much. It helps them to feel normal that they'll take the film and they'll put it in the Bible and they'll let it melt and they'll eat a page right out of the good book. And this happens, right? And they do these random screenings just here in Nevada. They had 50 inmates, 21 tested positive for Suboxone. We don't know how they got it, but they got it. It's huge. It's interesting. Okay, next slide. So, this I kind of like better here. So there's buprenorphine, partial agonist. So it doesn't plug in completely. It's slower acting, it's longer lasting. If you're an addict, it attenuates the rush of sensation. The plummet is eliminated. Your pain is maybe relieved without the self-destructive behavior. But how did we get to this? How did we know that buprenorphine did this? It's really odd, you know. The backstory, it's very interesting because it just didn't show up one day like this. So back in the late 60s in Britain, there was a company that made two products, mustard and furniture polish. This is the truth. And they had some chemists there, and they asked the chemists to try to figure out a way to beat morphine. They wanted a less addictive painkiller. And so these chemists are still alive today. And so they were able to synthesize buprenorphine, but they didn't know what it was. All they knew was that in their lab, the monkeys they had, they were seeing this great pain relief at these unusually high doses that seemed safe. But they were kind of scared. They didn't want to come out with it. So they said to their friends, they said, well, you know, we want to make sure this is what it's doing. So we're just going to test it on ourselves. The first human test were on themselves. So they go to an infirmary in Glasgow. They have some buddies there. And they said, we're just going to take this compound we synthesized. We want you to watch us and just make sure we're okay. Ridiculous. So they take it. And of course, they go out of their mind because they're opiate naive. But they notice the same effect. And they also notice a high incidence of nausea and vomiting, which is probably what we notice with buprenorphine sometimes. So we get to that. How does it get to the United States? Well, here's the story. In the early part of the 70s, in Lexington, Kentucky, there was a prison. It was a prison, it also had addicts, and it also housed the Addiction Treatment and Research Center of the United States. How would you like this phone call? Hi, we're the company that supplies your mustard and your furniture polish. We have something that, you know, we think might be helpful for you. And their answer, because it's the 70s, was radical. Far out, man. God, I hate the 70s. I said, that's how it got over here. The whole compound is just shipped over here. And they were desperate for it because they were sick of methadone. It was stigmatized. They had all these addicts walking around. They wanted something else. And remarkably enough, it was life-changing. Psychiatrists in the hospital at the time would talk about how they had these people that would walk into their office with tears in their eyes because they felt normalized. Something was plugged in and they could go about their daily activities. Crazy that this happened. Crazy because, I mean, you had nothing, no trials, no nothing, but they were prisoners. They didn't care. Anyway, it took off from there. Fast forward 33 years, the pharmacist at that prison became the executive vice president of the company that makes brand name Suboxone film. Circle gets the square. Isn't that funny how that works? The federal government then realized they had such a huge deal. They financed $100 million of clinical trials to get Suboxone on the market the way it was as the film. And from this relationship, it explains why it's been so difficult to get other generic products, why we have all these crazy brand names we're going to talk about, all this other ridiculous dosing in different milligrams. It all kind of makes sense when you look at it. I like to put this opiate comparison up here because it's always such a problem for us when we look at, and we'll get more into details of this later on, who's been taking what, and then what do I do with it? The half-lives are in the middle, and then on the right are all the equivalent doses. you know, tramadol is a very interesting point here because a lot of times we don't think about it as equivalent on some level, but it is because it acts on opiate receptors. And then there's buprenorphine on the bottom. So here's everything that's commercially available today. We have patches, we have films, we have tablets, we have an implantable one now that we don't have any experience with. One side note that I'd like to mention with regards to naloxone, why it's there. It's there because it does nothing. It has nothing to do with the plateau effect. It has nothing to do with the sensation, absolutely nothing. The DEA had insisted in clinical trials that it was put in as an abuse deterrent, which means that if it was snorted or if it was injected, I said it would create mildly unpleasant sensations for someone. And that's why it's there. When it's taken as the film or the tablet, it's pretty equivalent to each other in the mouth. The naloxone itself in the component is very hydrophilic. It just hangs out in the saliva. When you swallow it, goes down the GI tract, deactivated by the liver, does nothing. But buprenorphine is very lipophilic. And this is what makes it cool in the sense that we can dose it the way we do, whether it's in the mouth or under the tongue or everything else. And we'll talk more about that later, but that's important to know. Let's go on to the next slide. This is kind of a very gross simplification of what we're going to be talking about later when we talk about the dosing of it and who meets the criteria, because Lord knows we're going to get into all the individuals that help us, whether we're dealing with the clinical opioid withdrawal scale or the addiction withdrawal scale. All these measurements we can use, right? And what a person's history is, everything else. So, and we can read this here. It says induction, based on the half-life of the prior opiate, obviously what they took before, but also too by the timing and what the patients report. Withdrawal symptoms. They have to be in somewhat of a state of withdrawal before we give it. And Dr. Brutt had said this before so perfectly. When you're dosing somebody, you're kind of backfilling those other receptors, building up that crutch before you let them go. Onset, 20 to 40 minutes. It's about the same whether it's the film or it's the tablet. It acts pretty quickly. Duration, 12, 20, 24 to 42 hours. Adverse effects. There is a whole list of adverse effects, and obviously there's a whole list of issues with people that have all these other indications, whether they have head trauma or other hepatic impairment, or they're obese, or they have thyroid dysfunction. We could talk about this forever. The biggest one is respiratory depression. Certainly they can overdose, but it's just less likely. We don't see it much. And pre-existing hepatic impairment, because it's metabolized by the liver, if they have severe liver issues, this might not be what it is. And of course, the abuse potential. Well, if you play in the bathwater, you're going to get wet. It's just what it is. Efficacy. We know that long-term drug use profoundly alters the brain. Craving, seeking, the taking, we know it's biobehavioral. You know, addicts will develop a tolerance to the euphoric effects, and we say they describe themselves as normalized by it. Their cravings are satisfied. This is why Dr. Altenson has said before many times, it is a chronic disease like hypertension, thyroid, blood pressure. We need something to make people be functional. A lot of the things that we do in the pharmacy is we try to look at drug interactions. And it's always kind of a lesson for us because it's always just a pain in the you-know-what, those liver interactions. We had an issue where we had an individual who was on a certain HIV medication. And we were all kind of freaking out because she was exhibiting these weird symptoms and she was on Suboxone. We thought, maybe it's a rash, maybe it's an allergy. We didn't know. Well, it turns out because we're so stupid, she was actually going through withdrawal. One of the things that we missed, we were underdosing on our buprenorphine because the HIV medication was inducing the crap out of her. Part of the word crap, but it was true. So we dosed her up on that and it just made all the world of difference. So these are things that we try to look at, you know, the big ones. The inducers, we all hear, you know, rifampin, and the inhibitors, you know, the azoles and so forth. These are things that we look at. And then finally on the bottom here, risk of congenital abnormalities. There is clear evidence that regardless of whether you're on methadone or on buprenorphine, if you are stable and you are functional, you stay on it. And as Dr. Broadhead had said before, whether you are pregnant or you're taking care of your child, those first few years of life are so important that you're there. Those connections are forming. You're human beings. They're not pets. Yada, yada, yada. Please One of the things that I'd like to mention too real quick, buprenorphine in general, it will diminish the effects of other opioids, but it won't entirely block them. So if you're treating pain or you're doing other things, you can do both. It's not unheard of. And with that, I'd like to turn it over to Carol.
Well, thank you. I'm going to jump into naltrexone. It's an exciting medication, and I'm afraid I don't have the history of naltrexone in detail, like the way buprenorphine was presented by Krish. But it is another option to use for opioid dependency. And we have the same sort of thoughts about how the opioids work with their receptors in the brain. So in the cortex, we have that portion where we have counseling that goes on, decision-making, thinking, reasoning, planning. That's where people have impact from their addictions, and it impairs that. Our medications don't specifically target that area. That's the area that we rely on our counselors, Danica, and the like. But the limbic region is an area that our medications can have some effect. That's where the endogenous opioid receptors sit, and they're the ones that are responsible for the release of dopamine. When we have the endogenous, the endorphins or dynaphrins, they will release a pleasurable sensation. But when you have opioids or heroin, you have 2 to 20 times the effect. So that pleasure is just enormous. So we're working to try and have an effect on something that is, just basically desirable. So when we talk about the receptors, we've talked about the agonist, the partial agonist. Now we have a medication that's an antagonist. Naltrexone sits on the receptor and has full capability of blocking the receptor. When you start with naltrexone, you can have it orally, which is generally what we do to begin with. And that way we can see if there's GI tolerability, how people do, that they make sure that they don't have any adverse effects, any very serious nausea, anorexia, dizziness, syncope, those sorts of things that can be side effects. Then we go to the injection. It does take 2 to 3 days before the onset. The injection lasts approximately 28 days. You have to realize when we do start this medication, there is an onset of action that takes a few days. During that initial phase, individuals can use opioids, heroin, and have some effect. That's when they may be vulnerable to some overdose. And as time goes on, that same effect tends to wane. And that's also when they can be using the heroin and have some effect. Other times than that, the heroin, the opioids have no effect on the patient because the receptors are totally blockaded. We can talk about some of the adverse effects, contraindications. As you can see, they do have some difficulty with toleration, and over time that improves. There's the nausea, fatigue, sedation, that if we just give them time and allow them to tolerate that, that does improve. There is the potential for hepatic toxicity, and we need to make sure that patients know that if their urine turns brown, if they have any of the symptoms of acute hepatitis, it may indeed be the naltrexone. There are reports of eosinophilia and pneumonia that are out there, so that's something that you should think about mentioning to the patient as well. The most important thing about naltrexone is you have to make sure that people are not on their opioids. They have to have their opioids out of their system. So it depends upon what they're taking. If they happen to be taking heroin, well, heroin does have a short half-life, 2 to 4 hours. They can oftentimes tell you when their withdrawal symptoms begin. But the recommendation is really to have the opioid or heroin or pain medication out of their system for 7 to 14 days. That's for short acting. If they happen to be on buprenorphine or methadone, then you need to look at 14 to 21 days as the time that they need to be free and off of any of their opioids. It's similar to buprenorphine. If you happen to give naltrexone to someone that has residual opioids in their bloodstream, that can precipitate really serious withdrawals that can be managed only in hospitals and potentially in the ICU. I've seen that just one time in my experience with buprenorphine, using that for transferring people from opioids for pain management. So that's the real worry. You have to be sure about where they are in terms of their last use. Other things that can happen in addition to the systemic adverse effects, you can have injection site reactions, and this can be pain, induration, ecchymosis, pruritus. They improve over time, but there can be severe reactions which may require surgical interventions. Generally, the local effect and the pain improves over the course of 2 weeks. It's important that it's an intramuscular injection and not just into the adipose tissue, because that lessens the likelihood of having a injection site reaction. So let's see, we're moving along. Other things that kind of come up with naltrexone, there's a concern about how do you reverse the naltrexone blockade for emergency pain management. Say someone has an automobile accident and they need to be in the emergency room. Similar to buprenorphine, you can override that. Usually parental fentanyl is the drug that's used for big emergencies. But if you do need pain management otherwise, recommendations are to use things that are non-opioid and analgesics. Ketamine could be an example of that, or to use regional anesthetics. So there are ways to sneak around the naltrexone, but it is not an absolute worry because there are opioids that can overrun the blockade. So then we move to the efficacy. There are a lot more studies about using naltrexone for alcohol than there are for opioids, and the efficacy and safety are proven, but the numbers are a little bit difficult to access. The pharmaceutical companies come out with their numbers, and I'm using that when we talk about whether our endpoints are, they look at studies to see are individuals staying off of their opioids for 85% of the days in a 5 to 24 week time, or what percentage are able to maintain the program to 24 weeks. And they really show that naltrexone does improve the likelihood of continuing abstinence. One study showed that 36% of patients compared to 35% of patients completed a 24-week program. That seems like a pretty low score to me, but that was it. But people will stay with a program longer with the naltrexone. Another thing that I thought was interesting is that we don't really promise our patients with naltrexone. There's more of a benefit with buprenorphine, but there are studies that show that the secondary endpoints of the studies are diminishing cravings. And naltrexone, one study reported a 55% decrease in the cravings from baseline at week 24. And with placebo, there was a 3% increase in cravings. So it does seem to have some effect that way. I think looking at the biochemistry, I'm not sure exactly how that craving really works other than there is the limbic system as well, that people know that they can't take it. So then perhaps they're looking for other things that can improve their dopamine and make them feel better. So that's pretty much where I am with the naltrexone. It's something that we like to use in our clinic. It's generally used after we've brought people in. We're sure that they have their counseling component in place. We start with oral therapy for 5 to 7 days, see how they tolerate it, and then it's a monthly injection. The studies have shown, or that look at checking urine drug screens. Every 2 weeks they have counseling, and then once a month with the injection. We're a little bit, we just continue with the counseling on a case-by-case basis. So that's kind of my portion of the
Yeah, thank you guys so much. I'd like to open it up to any discussions or questions or patients.
This was such an exciting topic.
Trying to make it exciting.
Do we have any questions for the panel? Patient cases that you'd like to discuss?
Are you using naltrexone?
Yeah, go ahead, Dr. Van Gilder.
Hi, good morning. I was just wondering how do you make the decision between naltrexone and Suboxone? Do you have a lot of patients on naltrexone?
Well, we have fewer patients on naltrexone than we do buprenorphine, but it is, sometimes people come to us and they're off of their opioids. For example, maybe we have a lot of individuals from the youth offender courts. They've been in jail, they're not on their opioids. You know, maybe they've moved through that period of cravings, and it's a nice insurance policy. Some people don't like to take buprenorphine because then they're, quote, starting on another medication that makes them dependent. And it's hard to get off of buprenorphine. So naltrexone is a nice option for those individuals that prefer not to be on another medication. And it's sort of an insurance policy too. You know, they won't have an effect from any use unless, as I talked about, that in the beginning of the dose and the very end when it's waning. So that's oftentimes what we use in decision making.
For me, the early studies with the opiate blockers, naltrexone, naloxone, showed that they're excellent medications. Long-term effects in terms of keeping people off opiates were similar to methadone. The problem is that it's a medication that nobody wants to take. So it works best in those who have a contingency-based treatment plan. In other words, if you don't do something, you go back to prison. So it works well in that particular population where there's a little added motivation for them to comply with the medication regime that they probably normally wouldn't. We use it a lot in physicians. Physicians who have opiate use disorders and they're coming out of treatment. A it's not uncommon that they'll be on either oral or intramuscular injections, especially if they're anesthesiologists. And in those particular groups, it actually works very well. For the general population, there's a couple of things that go through my mind. Number one, from a biological standpoint, how many times has this individual tried to get off opiates, and how successful have they been? So somebody who's early on in the process, they may have a year or less of only oral opiates. They've been able to get off for 3 or 4 months at a time, but because of their environment or availability of drugs in the house, they found that they relapse. They relapse. They've got a good social support system. They're still employed. They haven't lost a lot of social skills. That's somebody who's a good candidate for naloxone. Somebody who's 35, giving an example of a 35-year-old white male presents himself to the VA. He's been using since age 12. The only time he's ever been off opiates was the couple of years he was in the military, and even then he was using oral opiates because he was always hurting his arm or his leg or his shoulder or something. The longest period of time he's been off opiates has been 6 weeks, and times he was in jail. He's got no social skills. He's got no job. He's got no family. He's homeless. This is a guy who's a long-term reclamation project, from my perspective. And so we're going to put him on Suboxone, buprenorphine, get the needle out of his arm, get him stabilized so he's not running around trying to run from one opiate to the next opiate. And now Maslow's hierarchy of needs comes in, and his opiates taken care of, and then we can look at housing, and then we can look at long-term recovery, and how to take care of yourself, and how to get a job, and somewhere down the road we'll consider taking them off opiates. So there are social factors to consider, and there are also biological factors to consider in making the decision between the two. Is that helpful?
Yes.
Also, sometimes we will use Suboxone because the patient will refuse injections. They just cannot tolerate it.
By the way, that's also the same approach I use when we've induced somebody on Suboxone, and now it's, am I going to do a quick taper on this guy, or is he longer term? And when do I start doing a taper? It's when there are all of those other issues that he's going to need to, or she's going to need to be able to be successful off of opiates. Have they got all those other pieces of the puzzle in place before we start tapering them?
Yes, again, that's, the medication just really provides a framework for us to allow the individual to get started with their counseling, rethinking their life, their strategies for coping, and maybe move them to the next phase. And the naltrexone, being the injectable once a month, kind of moves them along the continuum too, so that they're able to have a little bit of a safety net underneath and be able to make their way out into the world a little further from our structure.
Can I ask a quick naltrexone question? Is there a sort of a standard time course of therapy? Do we commit patients to, for all intents and purposes, lifelong therapy? And what sort of adjunctive approaches do you use to patients who are kind of in this, in a course of therapy with naltrexone?
I think it's a case-by-case basis. There are the adjunctive therapy that goes along with it. Really, are we treating a secondary depression? Are we treating anxiety? Do we have a substance abuse counseling going on? Are we making sure, as Dr. Broad had said, that all of their social structures are in place? So I think it's really case by case. I don't have the experience with life for years, and I'll have to defer to our psychiatrists here to see.
We have several patients that have been taking Vivitrol for more than a year, and I think maybe one or two almost up to a year. And a couple of those are really kind of done with their therapy piece. And it's just like occasional, they still go to some groups, they still come in to see a therapist every once in a while, but their support system is pretty much in place. And they just take it because they just like having that safety net. So it could go on, and as long as their liver is, healthy enough, they can continue doing that. And we even have one patient specifically that has Hep C, but because he's been able to stay clean off the drugs for so long, he's been taking Vivitrol almost 2 years, and his liver enzymes are dropped way low, to the point where he doesn't even need treatment for Hep C at this point. So they can stay on it for a long time. It's just, most of the patients that stop are just comfortable in their life, and they feel like they don't really need anything else, that safety net. And that's more because they've been able to build up a support system in their life, and they replace it with other things.
Thank you.
Yeah, most of the, if they're going back to our physicians that we follow, we monitor our physicians for 5 years. And we want them off all of the medications before 5 years, because that's when we turn them loose. So if they're going to have problems, we want to have those problems before they are no longer monitored. So that's the only environment where I think we've got, in my experience, where we've got a time frame to say, we got to get you off that to see how you do before 5 years. Everybody else is a lot more open-ended. And I've had a number of folks come on and off medications, orals. I usually generally stick to the orals for a longer period of time. In my experience, the one thing that it really helps with is everybody's going to entertain the thought of using again. That's part of the general condition. The thought is going to come through your mind. So everybody entertains the thought. What naloxone can do is help make that thought no longer entertaining. So you entertain the thought, but you don't find it entertaining. It doesn't give you an immediate dopamine release. It's kind of like if you can think of your favorite food and in your favorite restaurant, that one time where, that was the most exquisite meal I ever had. You begin to feel good about it. That's a dopamine release. Okay, that dopamine release is followed by an endorphin release, and you feel good about it. But if you're sick, okay, or you're nauseated, or you've just eaten, evoking those memories doesn't bring up that same feeling. So one of the things that Revia or Vivitrol can do is help block that emotional response, so you can entertain the thought, but you don't find it entertaining. And as you build in with therapy, the ability to think through the drink or think through the use, look at all the negative consequences, look at all the things that you lost, and you decide, nah, I don't want to use. That's a good time for them to consider coming off the Vivitrol, coming off the naltrexone, is when they have gotten to the point where they can entertain the thought, but they no longer find it entertaining. That's the time that they can come off of it.
Perfect. So we have a question here. What are some of the most common reasons for non-adherence to MAT / reluctance to engage in MAT from the patient's perspective, and strategies to deal with that?
You guys want to go first?
Go for it, Danny.
Oh, yeah.
Well, I think there are a lot of reasons, and it sort of depends on the patient and where they come from. We have some patients who are court mandated, so that's an entirely different sort of approach than somebody who's coming in kind of just on their own volition. So for some patients, their hesitancy, like Carol had mentioned earlier, was, there is still stigma around medication-assisted treatment, where if I'm taking, a medication, that means that I'm still in an addiction. So that's something that we wrestle with. And, there's just a lot of education that has to go into that. We spend a lot of time, we're fortunate in our program that we have a team where we get to spend a lot of time with patients, and they get to hear from multiple sources, information that, is helpful for them to make good decisions for themselves. So they're hearing it from the doctor's perspective, from a nurse's perspective, from a, therapist's perspective. And so in our program, we use a lot of motivational interviewing. I know we talked, I had mentioned that a little bit in one of our previous sessions. And I'll say again, if you're not familiar with motivational interviewing as a technique to use with your patients, I would really, really strongly recommend that you do that. And not even just for MAT, but just for, compliance in general. And just, it's such an easy way to help patients sort of find that internal motivation, rather than, because none of us like to be told what to do, even if we know that what we're being told is the right thing. We're naturally rebellious. And so if you can talk to a patient in a way that kind of helps them come to that decision on their own, you're going to have a lot better buy-in to any kind of medical intervention. And you're also going to have more successful patients. So that would be something I would really recommend.
Well, oftentimes you do have to fight back from other, an individual comes and says, well, I know people that have been on Suboxone, they can't get off of it. Well, I know. So you really have to enter in and explain, we're trying to have them become successful, and the likelihood of success really is higher using these medications initially. And that's something that is pretty much proven and shown, and just to be able to use that as an opportunity to gain trust so that they do see that what we're trying to do for them is in their best interest as well.
So, they may want to use again.
Yeah.
And that's one of the reasons why they're not going to take the drugs, because it's a buzzkill.
Literally.
Yeah, exactly.
Yeah.
And so that's one of the reasons we also monitor their urine buprenorphine levels, is to make sure they're taking it as directed. So they may not want to stop using. They want it, but they don't really want it yet. Number two is they don't want treatment. If you talk with a lot of these folk, is they want the fantasy of being off the drug. And they want the fantasy of a normal life. But there's a lot of steps in between, and they kind of skip to the last chapter of the book. And when you get into chapter 2 and 3, they start thinking, well, this is hard. You want me to do stuff other than not use. And so they may quit because our therapy is too intrusive. Or what we're asking them to do is too difficult for them, or they think it's too difficult for them at that particular point in time. So it may be they want to use, it may be they don't really want to engage in therapy for a lot of different reasons. And it also may be because they don't want to, quote, be addicted to the other drugs. So it's kind of odd that I'll keep shooting heroin, but I don't want to take your pill.
Yeah.
But it really comes down to they don't,
Right.
In their mind, it's all one and the same thing. And in some ways it is, but, again, using motivational enhancement techniques, some cognitive behavioral methods, you can usually get them to come around to, yeah, well, what I'm doing ain't working, so maybe I'll try your way. And if it doesn't work, it's always good to work out with them what plan B is going to be. Well, if you don't want the drugs, then what's your plan B?
And I would say too, in cases where patients are being, non-compliant, it's really important just to sit down and have a conversation because, sometimes we have patients who, for example, they really do want to be in the program and they want to do well, but they're in a relationship with somebody, maybe their primary support person, their partner, who is not supportive and who is still actively using. It's really hard to be compliant with the treatment program when the person that you're living with is using. So just kind of talking to them and figuring out like what is getting in the way, what are the barriers, what is making this difficult for you, rather than making assumptions, so that then you can really kind of get to the bottom of it and then find solutions.
A lot of them have other addictions that they haven't disclosed, and if they start buprenorphine or if they start naltrexone, then they're going to be monitored. They don't want to reveal that they're still using other substances. So there's always something that's either they still want to use heroin or there's maybe something else that they still want to use.
Go ahead, Dr. Van Gilder.
Hi.
Do we have any other questions or cases for the team? Everyone is on mute, so if you do have something, please unmute yourself with the icon in the lower left corner of the Zoom screen, or if you're on phone, it's *6.
Well, I've got a few. Might take a bit to get kind of through them. If you guys are open to kind of discussing some of these things.
We got time.
Yeah.
Yeah. Okay. So to start off with, allergy to Suboxone, naloxone. I've kind of seen it across the board where it's gone so far as pharmacy will not prescribe or will not dole out Subutex unless there is some sort of proof, and I don't know what that proof needs to be. How do we handle this situation? What sort of, what's the standard of care here when it comes to needing to document an allergy to Suboxone?
So the dispensing pharmacy is saying that the patient
Absolutely, yeah.
rash or something like that, and so they won't do it?
Right. They're saying no, not until you have some formalized, documented proof of an allergy. And let me preface this with I think on the East Coast, where oddly enough is where like the crisis in the heart of the epidemic is, patients have the highest obstacles or the largest obstacles to overcome.
Ourselves.
Yeah. So it's really unfortunate, but that's the general consensus that I get. So yes, so pharmacies just will not dispense.
That's very peculiar to me. It's very interesting. The whole process that the pharmacy lives in is just documentation, and it seems like there's almost something else going on, because if a patient says to you that, and then 9 times or 10 times out of 10 you call the doctor and the doctor says no, this is what it is. You document that, and realistically, I mean, you have covered yourself. You've done everything legally that you're supposed to do. I mean, it always boils down to, if you're a pharmacist, is it unethical? Is it illegal? Is it immoral? Although obviously not any of those. Or will it cause harm to the patient? I mean, that's number 4. I don't really understand that at all. It almost seems like the patient is maybe saying something else to the pharmacy, or the pharmacy is just a complete D-bag. But I don't really understand that at all, because at the end of the day, everybody's trying to do the right thing, and you're trying to do what's in the best interest of the patient, and that's always kind of your guide. So that I'm so sorry you have to deal with that. I mean, you seem like a very reasonable person.
Let me see if I got this straight. You are saying that you have written a prescription for Subutex for just pure buprenorphine, and the pharmacy won't fill it because they want documentation that the person has an allergy to some other component in the buprenorphine
Naloxone product.
naloxone combinations.
Right. Yeah. And in
Now, do
it,
you think that they've got that? Do you think they've got an allergic reaction to it?
so great question, which was going to be my follow-up is where do we draw that line, right? So if a patient comes to us and says, I've been on Suboxone, I've tried Suboxone in the past, and I had nausea, vomiting, violent headaches, whatever it might be, what do we do? What do we do? I mean, do we give them a test dose of Suboxone? Do we
Yes.
not take them for their word?
No.
So it's a sticky situation. But yeah, so in that
For me, it's pretty straightforward. I'm going to test them with Suboxone. Okay, I'm going to test them with Suboxone unless I've got a letter that says Dr. So and so has in these situations fully documented that they had these issues. I'm going to test them with Suboxone because in my experience, 99 times out of 100, what's happened is that they haven't waited long enough to do a buprenorphine induction. And buprenorphine will throw you immediately into withdrawal if you still have enough opiate in your system. And I load you with 4 to 8 milligrams of Suboxone. I'll do it each and every time. So a lot of times it's not an allergy to naloxone or naltrexone that's the problem. It's you're throwing them into withdrawal by using a partial agonist.
We have a patient who was taking the Suboxone films and was getting a rash, and it developed about like a week or two after she started it. And then we switched her to the tablets, Suboxone tablets, buprenorphine, naloxone, and the rashes went away. So we found that maybe she had some type of allergy to whatever was in the films.
Yeah, the polymer,
So
the binder, or the dye. I mean, it could be anything.
I think it was.
Yeah, it was the dye.
it was the dye.
We didn't switch her to Subutex. We kept her on Suboxone, but we just did the tablet forms, and the rashes went away.
But a rash is very different than nausea,
Nausea,
vomiting.
Right.
That's
If it
a-
looks like withdrawal, I'm going to
Yeah.
call it withdrawal and suggest that we wait longer next time around, or we do a different type of induction. There are a lot of different ways to do alternative inductions, depending upon the opiate that they're using. Trying to induce somebody on Suboxone who's coming off methadone is a very different kettle of fish than somebody who's coming off heroin. So there's other issues involved with that. It depends upon what type of symptoms they're claiming indicate that they're having some type of allergy. But it's still very different if your pharmacy's going, I'm not going to fill that because I've got a different set of requirements that I've made up in my head.
Right. And that was just sort of a food for thought because I mean one of the biggest things we run into is that Subutex is only for pregnant people. That's it. That's the only indication is pregnant patients. And then that's also a topic for discussion, right? Which is one of the other things I want to bring up is I don't believe it. I don't think the data even supports the teratogenicity of naloxone.
That's
correct.
None.
Just says
I mean, there's just there's nothing. But I doubt it.
Literally nothing. So I think even that's a fallacy that they're kind of basing that practice off that too. So a question: have you guys run into patients who are getting DWIs for being treated with Suboxone, but not the initial sort of infraction was not getting pulled over for like erratic driving, right? That was suspicious of DUI or DWI. It was speeding or tail light or whatnot, and the fact that they have been found to be on buprenorphine product automatically got them the DWI charge, and now they're sort of in this legal battle because of it. I try to find what sort of the stance is, and I don't know. It kind of seems like it might be state dependent, but even there, it's very unclear.
I think it is. You know, a lot of the times when you have a prescription, that kind of overrides everything because you're under treatment and you're under care and you have a contract, whether it's pain management or anything else. I mean, usually we always tell patients when they're picking up, it's like, look, this is what it is. It's a narcotic. This could happen, but, you know, that being said, you have a prescription and you also have a responsibility to make sure that, you know, you feel you can engage in behaviors responsibly.
Yeah, absolutely.
I mean, you know, considering what some people take and then it never goes any further, I mean, I've seen the police when they look at the bottles, this and that, and then it just stops right there because I don't know what recourse, you know, they have. Yeah, that's very interesting.
How many people would be able to drive on the freeway if their medication was going to come up as a, you know, under that thing?
We recommend that they don't drive if they are on Suboxone. That's our recommendation, and of course what they do is different than what we say.
So is that recommendation based off of the fact that, I mean, is that coming from somewhere?
Medication label, side effects.
So I was under the impression that the label says, you know, see how you respond to the medication before driving and operating heavy machinery, not the recommendation that they do not do that while under treatment, because then that kind of you can tell everyone.
General, like, you know, be cautious if engaging in woodworking and other types of activities.
Right.
It doesn't say
careful.
Do not.
Do not. It does. Right. It does not say do not.
Well, it won't say that.
Yeah.
And it's interesting too, you know, because you have a lot of people that will apply for a job, you know, and they'll flag a screen, but you know, you have the prescription, you're being treated. So I mean, what's the difference if you're getting? I don't know.
I've got a couple of Suboxone patients who are long-haul truckers, and they're well known to be long-haul truckers. They've been on this 7-8 years, no problem. So I think it's a jurisdiction by jurisdiction issue, and the real question is, can they win it in court? So that's more of a legal issue than it really is a medical issue. Certainly anybody can become intoxicated with this stuff, which gets back to a previous question. I wanted to make sure, you know, everyone understands that while your average addict may not have as much of a problem overdosing on Suboxone, it'll kill your 4-year-old. Okay, these are opiates.
Yeah.
They will, you know, kids will die. High school kids will die if they're drug naive. So, I mean, you can kill yourself with this stuff by accident, generally in combination with other medications. But if you're narcotic naive, it'll kill you. I think that's probably a greater risk than DUIs, because, I mean, half of my guys, they were on 300 milligrams of oxycodone a day, and they were driving the freeway.
Yeah, drinking a Monster and a Red Bull and taking Sudafed. I mean, come on.
Off you go.
Exactly. And I guess, and an extension of that is, are you guys aware of any professional societies or organizations, nursing, physician, whatever it might be, law that would not allow you to be on buprenorphine treatment?
Absolutely.
To get
Yeah, there are a number, and these are boards of medicine. Most boards of medicine will not allow physicians to be on buprenorphine and work. Nursing boards, but again, it's going to vary from state to state. But just like they won't let them be on methadone, they won't let them be on Suboxone. It's my professional opinion that they shouldn't. And our long-term recovery rates for physicians who've got opiate dependence without using MAT, or at least without using opiate agonists, is just as good as those with opiate agonists. You know, they do fine. But they're a different kettle of fish than our average folks walking in the front door of Hope's or the VA.
Totally different.
Yeah.
Are you able to prescribe? If it's just, do you need to get a data 2000? So, question for the pharmacist. Are you able to prescribe buprenorphine naloxone? Personally, no. We don't have any collaborative practice room to do that. If yes, is this through a product you need, a data 2000? No, I mean, as far as I know, within the State Board of Pharmacy, at least here, there is no framework for any type of dealing with any controls of that nature. At least the laws in Nevada, they will allow pharmacists through an agreement. You could make substitutable changes within like hypertensive meds or antidepressant meds. I don't know if any controls a pharmacist could, and I honestly don't know why they would want to. It changes the scope of our practice. So. And that's just for Nevada, obviously. I mean, other states could have it differently. And maybe this will change when we talk about people getting access to things. I don't know where that's going.
And is that different from, I know you guys have like a standing, I don't know what you call it, for Narcan?
Yeah, there's standing orders. So those will be passed out from the medical director. So there would be a standing order for Narcan or naloxone. Or you could even do a CPA agreement for like immunizational practices and biologics, but nothing for this that I know of, at least in Nevada. So.
Is anyone currently prescribing Vivitrol to any of their patients? Just wondering, because it can get very tricky when you get to naltrexone oral tablets is simple enough to prescribe without any insurance problems, but when you go to Vivitrol, there are some little tricks to being able to get it ordered and have it paid for by medication or by insurance, and also you have to sometimes work through a specialty pharmacy. So if you have somebody interested in Vivitrol, we know how to kind of work with that.
All right, any other questions before we finish up? Okay, thank you so much, everyone.
Thank you.
Thank you.
Thank you all. Learning so much. Appreciate it.
Go.